Imagine a patient is rushed into an emergency room.
Right.
They have a severe, deep, penetrating gunshot wound to the pelvis. Absolute chaos.
Pure chaos, yeah.
Now, if you are anything like me, you probably assume the surgeon's very first instinct is to, find the hole, sew it up tightly, and stop the leak.
Oh, absolutely.
I mean, it feels like basic common sense. High-stakes carpentry, right? Find the broken part, patch it, close it up.
Makes total sense on paper.
But if you look at how modern trauma surgeons actually operate today, for certain deep pelvic wounds, they might purposefully leave the bullet hole completely open.
Yeah, they don't sketch it.
They don't try to close the tear at all. They just leave a busted, leaking pipe right there inside the patient.
It sounds completely counterintuitive.
Right. So welcome to this deep dive. We are taking you with us on a highly specific, intense, and incredibly surprising journey into the human body.
It really is.
We've got a stack of clinical notes and surgical principles focused entirely on the pathophysiology, the trauma, and the management of the rectum.
And it is a massive stack of source material, let me tell you. It covers everything from, highly detailed anatomical maps to the absolute cutting edge of modern cancer trials.
Yeah, it spans a lot of ground.
But the running theme across all these documents is a concept we can call the Surgical Thinking Academy.
The Surgical Thinking Academy. I like that.
Right. We are looking at how surgical minds actually process a crisis in real time.
How they make those high-stakes calls.
Exactly. How do they make life-altering decisions about an area of the human body that is, honestly, anatomically treacherous?
Yeah.
It's highly sensitive and just packed with critical blood vessels and nerves.
Okay, let's unpack this. Because stepping into the Surgical Thinking Academy means, well, checking your common sense at the door.
You really have to.
You have to stop thinking just about the scalpel and start thinking about biology, elemental physics, and even human development before birth.
Embryology, yeah.
And the absolute foundation of all surgical thinking is the map. You cannot fix a problem if you haven't perfectly mapped the territory.
That's rule number one.
So to understand this specific surgery, you first have to understand the very strange geography of the rectum.
And the physical space we are talking about is remarkably small. I mean, it is a structure only about 12 to 15 centimeters in length.
Which is tiny.
It is. But within that incredibly short distance, the biological rules of the body change dramatically.
Right.
A great example of this is its relationship with something called the peritoneum.
Okay, remind me what that is again.
The peritoneum is a thin protective membrane. It basically lines your abdominal cavity and wraps around most of your digestive organs.
Okay, yeah. And the sources describe this anatomical relationship in such a vivid way.
They really do.
Like the upper part of the rectum is fully covered by this peritoneal membrane on the front and on the sides.
Right, totally wrapped up.
But as you move down, the middle part is only covered on the front. And by the time you reach the lowest part, there is absolutely no peritoneal coverage at all.
None.
It's like wearing a winter jacket that slowly vanishes the further down your torso you go.
That is a perfect analogy. And that lack of a protective jacket in the lower section makes the lower rectum highly vulnerable.
Because it's just exposed down there.
Exactly. It is locked deep inside the funnel of the bony pelvis, and it's surrounded by this dense web of nerves and major blood vessels.
Sounds like a nightmare to operate on.
Accessing it surgically is notoriously difficult. But the most critical geographical feature in this entire region, the absolute most important line on the surgeon's map, is a boundary known as the pectinate line.
The pectinate line. Reading through these clinical notes, that line jumped out at me like an international border checkpoint.
That's exactly what it is.
Right. Located right in the middle of our pelvic floor. Above this line, the traffic, and by traffic, we're specifically talking about lymphatic fluid drainage flows upward.
It goes deep into the abdomen.
Right. It follows pathways called the inferior mesenteric artery and vein. But the moment you cross below that exact same line, the rules flip entirely.
Everything changes.
The fluid drainage goes down and out, traveling toward the groin and the superficial inguinal lymph nodes.
It is a massive invisible boundary. And the reason it exists goes all the way back to human embryology.
Back to when we were fetuses.
Exactly. This line represents the exact point where two entirely different types of embryonic tissue met.
One growing downward from the inside.
Right, and one growing inward from the outside.
Yeah.
They met and fused together when you were just a developing fetus.
Okay, but I have to push back on this a little bit.
Sure.
Why does a surgeon operating today care about a fusion event that happened before a patient was even born?
That's a fair question.
I mean, Why does an embryological boundary dictate how a modern doctor uses a scalpel on a fully grown adult?
What's fascinating here is that the lymphatic system is the biological highway that cancer uses to spread through the body.
Oh, wow. Okay.
Yeah. So if a patient presents with a malignant tumor located just 1 single centimeter above that ancient embryological pectinate line, the surgeon knows with near certainty that the microscopic cancer cells will likely spread upward.
Deep into the abdominal cavity.
Exactly. But if that exact same tumor is located just 1 centimeter below the line, the cancer is going to track outward toward the groin.
That is wild.
Understanding that fetal fusion boundary dictates the entire surgical strategy. A surgeon isn't just trying to remove a tumor.
They are trying to dismantle the specific highway system the disease might have used to escape.
You nailed it.
Which brings us to perhaps the most legendary concept in this entire stack of surgical notes.
Oh, the holy plane.
The Holy Plane, yes.
Yeah.
To explain this, the sources use some pretty intense anatomical terminology.
They throw a lot of big words around.
They mention structures like Denonville's fascia on the front side and Waldeyer's fascia on the back side.
Right.
Now, a fascia is essentially a dense, tough sheet of connective tissue. It's like biological shrink wrap.
That's a great way to visualize it.
And sitting delicately between these fascial layers is what a pioneering surgeon named Bill Heald called the Holy Plane.
And Heald's discovery of this specific plane radically revolutionized how we perform cancer surgery.
Total game changer.
He developed a procedure called total mesorectal excision, or TME. Because before Heald mapped this out, surgeons faced an absolute nightmare in the pelvis.
Because of all those blood vessels and nerves we talked about.
Yeah, the tissue down there is dense, fatty, and it bleeds heavily. Surgeons would just kind of dig in and try to scrape the cancer out.
That's messy.
It was incredibly messy. And because it was so messy, they frequently left microscopic cancer cells behind, and the disease would just return.
I was trying to picture that earlier method, and the best analogy I could come up with is trying to scrape creamy peanut butter out of a thick shag carpet.
Oh, man. Yeah.
You are never, ever going to get it all.
That captures the frustration perfectly. But Heald realized that the body had actually done surgeons a massive favor.
Oh, so?
The body packages the rectum, its surrounding fat, and all the local lymph nodes inside a distinct fibrous fascial envelope.
Like it's already bagged up for them.
Exactly. The Holy Plane is the microscopic, bloodless space situated just outside that envelope.
Wow.
If a surgeon can locate that exact anatomical seam and dissect carefully along it, they can lift the entire cancerous package out perfectly intact.
That is incredible.
They never breach the envelope, and they never spill a single cancer cell into the surrounding tissue.
It is brilliant. You aren't hacking through the disease. You are finding the body's natural manufacturing seams and just like gently unzipping them.
It's elegant surgery.
So that is the map. That is the meticulously planned, carefully controlled environment of a planned operation.
But things don't always go to plan.
Right. Let's leave the planned surgery behind and transition to pure, unadulterated emergency. What happens when that beautiful map is violently torn apart?
This is where the principles of the Surgical Thinking Academy are tested under maximum pressure. We are moving into the trauma bay.
And the sources are very clear that penetrating trauma, things like gunshots, shrapnel, or impalements, are significantly more common in this area than blunt force trauma.
Like from a car crash, yeah.
Right. Surgeons actually grade the severity of these injuries using something called the AAST scale.
Which is a system that maps out tissue destruction.
From a mild grade 1 up to a catastrophic grade 5. But what really caught my attention was the classical surgical dogma for dealing with a massive injury down there.
The 4Ds.
Yes. For decades, surgeons lived and died by a rule called the 4Ds.
Divert, drain, direct repair, and distal washout. Those 4 steps were the absolute unquestionable gospel in trauma surgery for a very long time.
And when you read the 4Ds, they sound like a completely foolproof, logical checklist for disaster management.
They make sense intuitively.
Right. Step 1, divert. You create a proximal stoma. This means you bring a healthy piece of the intestine out through the abdominal wall.
So that stool empties into an external bag.
Exactly, completely keeping traffic away from the injury site.
Yeah.
Step 2, drain. You place physical plastic drains into the presacral space.
Which is that hollow, recessed area just in front of your tailbone.
Right, to suck out infected blood and fluid. Step 3, direct repair. You actually sew the hole shut.
Get in there and fix it.
And step 4, distal washout. You flush the remaining lower bowel clean. It makes total sense.
The logic was sound for its era. But, Surgical thinking is never static. It evolves based on patient outcomes.
And the notes highlight a massive shift here.
A fundamental paradigm shift in how modern trauma surgeons handle these injuries today. And the entire shift depends entirely on where the bullet hole is located relative to that peritoneal jacket we talked about earlier.
Yes, and this is the exact scenario I mentioned at the very beginning of the deep dive, which completely blew my mind.
The modern approach.
The modern approach dictates that if the injury is intraperitoneal, meaning it is high up and covered by that protective membrane, you treat it like a standard colon wound.
You go in, you do a primary repair, and you sew the hole tightly shut.
But if the injury is extraperitoneal, meaning it is deep down in that cramped, vulnerable, membrane-free lower pelvis, the modern rule is to do the diversion and to place the drains.
But routine direct repair is no longer required.
If the hole is hard to reach.
The surgeon will literally leave the traumatic wound wide open.
Which brings me back to my plumber analogy. How is it medically sound to just turn off the water main, but leave a completely busted, leaking pipe inside the wall?
It sounds crazy.
How is leaving a bullet hole open safe for the patient?
This raises one of the most important questions about how human tissue actually heals. In the heat of trauma surgery, you constantly have to weigh the threat of the disease against the danger of the treatment.
Okay.
The lower pelvis is an incredibly cramped space. It is surrounded by hard bone, and it is interwoven with a massive network of veins that do not contract when cut.
So they just keep bleeding?
Nonstop. If a surgeon goes digging around in a pool of blood down there,
Yeah.
blindly throwing stitches to close a hole they can barely see, they're going to cause massive catastrophic collateral damage.
Wow.
They could trigger a hemorrhage that kills the patient right there on the table.
So the surgeon's aggressive attempt to cure the problem instantly becomes more lethal than the original wound.
Exactly. The brilliant insight of modern trauma care was realizing what actually kills the patient.
What is it?
The physical tear in the tissue isn't the primary lethal threat. The threat is the constant stream of feces leaking through that tear and causing overwhelming sepsis. So by completing the first D, the diversion, creating the stoma to reroute all the traffic, the surgeon neutralizes the lethal threat.
They turn off the water main.
Right. Once the area is bypassed and the drains are clearing out the initial mess, the body's innate healing mechanisms take over.
It just heals itself.
The tissue will slowly generate healthy scar tissue called granulation tissue and patch the hole on its own. It heals far better in a clean, diverted environment than it ever would if a stressed surgeon hacked it together in a chaotic trauma bay.
It is a profound lesson in knowing when less is more.
Absolutely.
Okay, when you explain the mechanism of sepsis versus hemorrhage, leaving the hole open suddenly sounds like the smartest move in the room.
You manipulate the environment so the body can do the heavy lifting.
So we've talked about trauma caused by external weapons. Now let's explore trauma caused by biology, life events, and ironically, medical treatments.
This is a tough section.
It is. Let's look at how surgeons rebuild things that are slowly broken over time.
We are moving into the world of complex reconstructions, specifically dealing with fistulas and inflammatory proctitis.
Right. A rectovaginal fistula is an abnormal, highly distressing tunnel or connection that forms between the rectum and the vagina.
It's terrible for the patient.
The clinical notes outline a long list of causes, but one detail stood out as particularly sobering. In the developing world, the absolute most common cause of these fistulas is obstetric trauma,
We're talking about the devastating aftermath of prolonged obstructed labor.
where they don't have access to emergency C-sections.
Right, resulting in severe fourth-degree tearing of the tissue.
And the timeline for treating these fresh obstetric injuries is really surprising to me.
The 3-month rule.
The golden rule is wait 3 months, surgeons prescribe conservative management, and just wait for a quarter of a year.
The logic is that you have to let the profound tissue swelling subside.
And amazingly, some of these deep tears will actually scar over and heal naturally once the inflammation drops.
Waiting is an incredibly difficult prescription for a suffering patient, but it gives the body a fighting chance before resorting to the scalpel.
But what if it doesn't heal?
Well, if the natural healing fails, or if the fistula is a chronic, highly complex case, the surgical engineering required to fix it is astounding.
Here is where it gets incredibly creative. For those stubborn, complex fistulas, surgeons perform procedures using a gracilis or a Marcius flap.
Let's talk about the gracilis.
The gracilis is actually a long muscle located in your inner thigh.
Yep.
During the reconstruction, a surgeon will physically detach one end of this thigh muscle, preserve its blood supply, tunnel it all the way up into the pelvis, and use it to plug the hole between the organs.
It's crazy.
It is literally like borrowing a piece of sturdy structural scaffolding from your leg to patch a load-bearing wall inside your pelvis.
It is a marvel of biological engineering. You are taking healthy, thickly vascularized tissue and importing it into an area that is heavily damaged and starved of blood flow.
Which perfectly bridges into another major cause of pelvic damage outlined in the notes.
Radiation therapy?
Right, radiation proctitis. This occurs when a patient undergoes pelvic radiation for something like prostate or cervical cancer.
The radiation successfully attacks the cancer.
But as collateral damage, it severely burns the nearby rectum. It leaves behind telangiectasia, which are these fragile, spider web-like blood vessels that bleed constantly, along with deep ulcers and strictures.
It's severe damage.
And to manage this, the notes list some wild treatments. Surgeons will use argon plasma coagulation, or APC, threaded through an endoscope, or they literally put the patient inside a hyperbaric oxygen chamber.
The surgical toolkit here basically abandons the scalpel entirely, relying instead on high-end chemistry and elemental physics.
But wait, if radiation is hailed as the life-saving cure for cancer, why does the surgical field have to dedicate massive resources, like literally shooting argon gas and using pressurized submarine chambers just to fix the cure's side effects?
It feels incredibly contradictory, I know.
It really does.
But the harsh reality of collateral damage is one of the hardest truths to accept in oncology. Radiation therapy does not discriminate.
It hits everything.
It shatters the DNA of everything in its beam path. The tumor dies, but the healthy tissue is permanently irradiated. The tiny capillaries that supply blood to the area are totally obliterated.
Oh, wow.
So if a surgeon tries to cut or stitch irradiated tissue, it won't heal. It will literally just crumble and fall apart because there is no blood supply to fuel the recovery.
So you can't use carpentry on rotten wood.
Precisely. You have to adapt the tool to the specific mechanism of the damage. With argon plasma coagulation, the surgeon uses a stream of argon gas to conduct a very precise electrical current.
Sounds like sci-fi.
It gently singes and seals those fragile, bleeding surface vessels without burning deep into the already weakened tissue wall.
And the hyperbaric chambers.
That uses pure physics. By putting the patient in a pressurized tube and having them breathe 100% pure oxygen, the extreme pressure forces oxygen deep into the starved tissues.
Right, stimulating the body to physically grow brand new capillary blood vessels where the old ones were destroyed. It's pure adaptation. And the notes show that surgeons use that same adapt-to-the-enemy mentality with infectious damage, too.
Yeah, dealing with infections is a whole different ballgame.
They mention sexually transmitted infections like LGV, which is a specific, aggressive strain of chlamydia that causes dense fibrotic strictures in the tissue.
And herpes, which causes distinct, agonizingly painful blisters.
The underlying lesson is that you don't take a scalpel to a herpes infection, you treat the virus. You have to know what kind of enemy you are fighting.
Identifying the enemy dictates the weapon. Which brings us to perhaps the most profound philosophical evolution in the surgical thinking academy.
The paradigm shift.
We've seen how surgeons meticulously map the anatomy. We've seen how they bypass trauma and how they borrow thigh muscles to rebuild the pelvis. But the ultimate level of mastery is learning when to put the scalpel down entirely.
This evolution really centers around two core ideas: protecting the patient's quality of life and knowing when to just watch and wait.
Let's tackle quality of life first.
Looking at severe pelvic floor disorders like refractory fecal incontinence. When medications and biofeedback completely fail, the gold standard treatment listed in the notes is SNM.
Sacral nerve stimulation. This represents a massive leap in how we view the nervous system.
It is essentially installing a pacemaker for your plumbing.
That's exactly what it is.
The surgeon implants a tiny electrical device under the skin that sends mild, continuous electrical pulses directly to the sacral nerves, which act as the control cables for the pelvic floor muscles.
So instead of physically cutting and tightening the sphincter muscle, they're just rebooting the electrical grid to make the existing muscle work again.
It restores vital bodily function without permanently altering the physical anatomy.
Which is amazing. But the most dramatic, hotly debated shift toward putting the scalpel down is happening right now in oncology.
The sources are packed with major clinical trial data on this. They talk extensively about a protocol called TNT, which stands for Total Neoadjuvant Therapy.
PNT.
Now, historically, if you had cancer, the surgeon went in first. But TNT flips the script entirely.
It really does.
The idea is to give the patient all of their intensive chemotherapy and all of their radiation up front, before any surgery is even attempted.
To use a military analogy, instead of sending the ground troops the surgeons in first to fight hand-to-hand, TNT is like calling in a massive, prolonged airstrike.
Chemo and radiation.
Exactly. A total airstrike to completely flatten the enemy bunker before the infantry ever steps foot on the battlefield.
And the true revolution is what happens after that airstrike.
The watch and wait.
Right. The notes heavily feature a pioneer named Angelita Habergama. She was tracking patients who received this upfront radiation and chemo, and she noticed something incredible.
The tumors were gone.
By the time the patient was prepped for the planned surgery, the tumor had vanished. So Habergama proposed a radical idea. If the chemo and radiation already killed the tumor, why are we still cutting the patient open?
Why not just watch them obsessively with MRI scans and wait?
You have to understand how radical the watch and wait approach sounded when she first proposed it.
Oh, the medical community pushed back hard. For a century, the absolute dogma of oncology was that you always operate.
And honestly, even reading about the watch and wait strategy now, it sounds terrifying.
It's a huge mental hurdle for a patient.
If I am sitting in a clinic and a doctor tells me I had a tumor, my primal overriding instinct is, cut it out of my body yesterday.
Of course.
How do surgeons possibly look a patient in the eye and convince them that doing absolutely nothing is the safest, most advanced medical move?
To understand the surgeon's logic, you have to look closely at what that operation actually entails. The standard surgery for a low rectal tumor is an APR.
An abdominoperineal resection.
Right. That surgery completely removes the entire rectum and the sphincter muscles.
Oh, wow.
The patient wakes up with a permanent colostomy bag. Their bodily anatomy is forever changed.
That's devastating.
So if the tumor has already been totally eradicated by the upfront radiation, achieving what we call a complete clinical response, then performing that massive life-altering surgery offers zero additional survival benefit.
But it completely destroys their quality of life.
Exactly. The ultimate goal of modern surgical oncology isn't merely survival. It is preserving the patient's humanity and dignity.
And the sources highlight a recent landmark clinical trial that proves this is the absolute future of medicine.
The dostarlimab trial.
It involves a drug called dostarlimab.
This trial produced one of the most stunning, jaw-dropping results in modern medical history.
The trial looked at a very specific genetic subtype of cancer. The notes refer to it as MSIH, or mismatch repair deficient.
Right.
Now, I understand what a genetic mutation is broadly, but why does this specific mismatch make the cancer so uniquely vulnerable?
So mismatch repair deficiency essentially means the cancer cells have lost their internal spell checker.
Their spell checker.
Yeah. Normally, cells catch and fix typos in their DNA when they divide. But MSIH cancer cells can't. They rapidly accumulate thousands of massive genetic typos.
Okay, I follow.
Now, dostarlimab is an immunotherapy drug. It doesn't kill cancer directly.
Then what does it do?
Instead, it strips the blinders off the patient's own immune system, suddenly allowing the body's white blood cells to clearly spot all of these highly mutated, typo-ridden cancer cells.
Oh.
And once the immune system sees them, it completely obliterates them.
And the results of giving dostarlimab to these specific patients? A 100% complete clinical response.
100%.
Every single patient in the trial had their tumor literally melt away.
It's incredible.
They needed no radiation, they needed no chemotherapy, and they needed zero surgery.
A 100% success rate in an oncology trial is effectively unheard of. It proves that sometimes the absolute best surgical decision you can make is to hand the reins over to the medical oncologists.
It is staggering. Oh, and before we begin to wrap this up, I have to throw in one vital, fascinating bonus fact from the pediatric notes.
Oh, right, the pediatric rule.
Because it perfectly captures how a surgeon must think. If a pediatric patient, a young child, presents in the clinic with rectal prolapse, the immediate ironclad clinical rule is that the doctor must test the child to rule out cystic fibrosis.
It seems so disconnected at first glance.
It is one of those brilliant red flag connections in medicine where a seemingly simple mechanical issue in the pelvis is actually the very first warning sign of a massive systemic genetic disease affecting the lungs and the pancreas.
It perfectly illustrates the core tenet of the academy. The surgeon can never afford to have tunnel vision.
You are never just treating a symptom.
You must always evaluate the entire biological system.
Yeah. So what does this all mean for you? We started this deep dive by talking about the Surgical Thinking Academy and how true medicine is nothing like simple carpentry.
Far from it.
Over the last several minutes, we've mapped out ancient embryological boundaries that quietly dictate modern cancer pathways.
We've covered a lot.
We've seen how modern trauma surgeons have learned that sometimes the safest, smartest way to fix a bullet hole is to route the traffic away from it and simply let the body heal itself.
Less is more.
We've seen them borrow muscles from a patient's thigh to rebuild a shattered pelvis and shoot argon gas to treat the devastating collateral damage of our own cancer cures.
True surgical mastery is clearly not just about knowing the mechanical steps to perform a total mesorectal excision or how to tunnel a gracilis flap.
No.
It is about understanding the profound, overlapping complexities of human biology, physics, and anatomy.
Exactly. It's having the wisdom to know when to divert traffic instead of attempting a dangerous repair.
It's knowing when to install a delicate electrical pacemaker instead of using a scalpel.
And above all, it's having the humility to step back entirely and let the body's immune system take the lead.
Which leaves us with a fascinating, almost paradoxical question to ponder as we close.
Lay it on us.
We are currently witnessing landmark trials where drugs like dostarlimab literally melt away solid tumors with a 100% success rate. We are seeing sacral nerve stimulators replace massive reconstructive operations.
Yeah.
As our understanding of genetics and our biotechnology reaches these incredible, unprecedented heights, are we rapidly approaching a future where the ultimate goal of the Surgical Thinking Academy is to render the surgeon's scalpel entirely obsolete?
We started by saying surgery was like high-stakes carpentry.
We did.
But maybe eventually we won't need to cut or nail anything at all. Maybe the best tool in the doctor's black bag will simply be knowing exactly how to ask the body to fix itself.
Something to think about.
Thanks for joining us on this deep dive.